Tossing and turning, staring at the ceiling, yeah, we've all been there. But at what point does a bad night of sleep cross the line into a real clinical issue? Well, in this explainer, we're going to pull back the curtain on insomnia. We'll get into how it's diagnosed and, more importantly, how it's actually managed effectively.
So here's our game plan. First, we'll pin down exactly what insomnia is and what we're really trying to fix. Then we'll walk through the diagnosis, dive into therapies, both with and without meds, touch on some special cases, and wrap it all up with some key clinical pearls you can actually use.
All right, let's dive right in. Before we can even begin to talk about solutions, we have to get really clear on the problem itself. So let's start by defining what we're truly up against with insomnia, and maybe more importantly, what a win actually looks like when it comes to treatment.
So, how do we tell the difference between just a rough patch and a real disorder? It all comes down to the pattern. We're not talking about one bad night. We're talking about having trouble with sleep at least 3 nights a week for 3 months or more. And, this is the key, it has to be causing real, significant problems in your day-to-day life. That's when it gets the official label, insomnia disorder.
Now this right here, this is a total game changer. Most people think the goal of treating insomnia is just to get more hours of sleep, but that's not it at all. The real primary goal is to improve how you feel and how you function during the day. It's about quality of life, not just quantity of sleep. That is a huge, crucial shift in perspective. Okay, so we know what we're looking for and we know what we're trying to achieve. Now it's time to put on our detective hats. To really get to the bottom of this, we need to do a thorough investigation to figure out what's really going on. And that investigation starts here. A super detailed sleep history is the absolute bedrock of a good diagnosis. We need to get into the nitty-gritty, not just bedtime, but how long it takes to fall asleep, how many times you wake up, and for how long. And we also have to look at behaviors, that late afternoon coffee or scrolling on your phone in bed that might be making the problem worse.
So what a patient tells us is absolutely critical, but let's be honest, it's subjective. Memory can be fuzzy, especially when you're tired. So the question is, how can we get some more objective data to see what's really happening night after night?
Well, we've got a couple of really useful tools in our toolbox for this. A simple sleep diary, kept for a week or two, is a fantastic start. But to get even more objective, we can use something called actigraphy. It's basically a fancy wrist-worn device, kind of like a fitness tracker, that measures movement. It gives us a much more detailed, data-driven picture of someone's actual sleep-wake patterns. And here is a massively important point. Insomnia rarely travels alone. It's often a symptom or a companion to something else. It could be anxiety or a chronic pain, or even a side effect from another medication. This is why you absolutely have to look at the big picture and screen for these other conditions. Okay, before a single prescription even gets considered, the absolute focus has to be on non-pharmacologic therapy. These behavioral strategies are the first-line treatment for a reason. They are the essential foundation for getting chronic insomnia under control. So let's meet the gold standard, cognitive behavioral therapy for insomnia, or CBTI. This is an incredibly powerful, multi-part approach that tackles the root causes. We're talking about stimulus control, sleep restriction, relaxation. It's not about a quick fix. It's about fundamentally retraining your brain and your habits around sleep. The cognitive part of CBTI is so important. It's all about identifying and then challenging those negative, unhelpful beliefs we have about sleep. Thoughts like, if I don't get 8 hours, my day is ruined. By reframing those thoughts, we can break that vicious cycle of anxiety that actually keeps people awake. Now, think of sleep hygiene as the basic rules of the road for good sleep. These are the things we should probably all be doing anyway, right? Like having a regular schedule and keeping the bedroom cool and dark. Now, on their own, they might not be enough to cure chronic insomnia, but they are an absolutely crucial piece of the overall puzzle.
Okay, so let's shift gears and talk about medication. While those behavioral strategies are always the foundation, pharmacology definitely has a role to play, especially for providing some short-term relief or when CBTI just isn't getting the job done on its own.
Now, this might look a little complicated at first glance, but think of it as a clinical GPS. It's a decision tree that helps guide the entire process, from that initial assessment all the way through every treatment choice, helping clinicians find the best path for each individual patient.
When we talk about sleep medications, it's important to know that they're not all the same. You've got the older benzodiazepines, which kind of work like a sledgehammer. They get the job done, but have a higher risk of dependence and other side effects. And then you have the newer Z drugs, which are more like a scalpel. They're more targeted in their action and generally have a better safety profile.
Now this is where things get really interesting. There's a newer class of drugs called DORAs, and they work in a completely different way. Instead of sedating you or knocking you out, they work by blocking the wake-up signals in your brain. And the best part? So far, the data shows no evidence of withdrawal or that nasty rebound insomnia when people stop taking them. It's a really promising development.
Remember how we said insomnia rarely travels alone? Well, this is where that becomes clinically really important. When a patient also has, say, depression or chronic pain, it often makes sense to choose one single medication that can help treat both conditions at the same time. It's a smart way to target the underlying problem and avoid piling on more and more pills.
All right, let's talk about tailoring our approach, because managing insomnia is definitely not a one-size-fits-all situation. Different groups of people need special considerations to make sure treatment is both safe and effective.
This is so incredibly important. When we're talking about older adults, pregnant women, or kids, we have to be extra careful. The first-line therapy is always going to be non-drug approaches like CBTI. And if medication is absolutely necessary, we have to prioritize safety above all else. That means avoiding certain drugs and using the lowest possible dose for the shortest possible time.
So to bring this all home, let's just boil it all down to the most important high-impact takeaways. These are the key management pearls to keep in your back pocket when you're dealing with insomnia.
If you take away only one thing from this whole explainer, let it be this. Success is not about chasing a magic number of hours on the clock. It's about educating the patient, setting realistic goals, and focusing on the outcome that actually matters, making them feel and function better during the day.
And finally, this is a really practical, real-world point. While we always aim for short-term use of sleep meds, we have to be realistic. For some people with really significant complex and chronic issues, stable, long-term medication might be the most appropriate harm reduction strategy. It's not ideal, but sometimes it's the necessary choice.
And that leaves us with one final thought to chew on. Given how tightly sleep is linked to how we function when we're awake, where should we put most of our energy? Is the biggest win found in perfecting the hours we spend asleep at night, or is it in better managing our energy and mood during the day? Something to think about.